And it's my pleasure to introduce Kelly Huang, the CEO of Elucid.
Great, thank you, Dr. Branch, Dr. Rubenstein. Thanks to SCCT for inviting us, and thanks you all for being here. Part of CCTA 3.0, our vision. As I look back, I mean, look at Campbell's talk, look at these other technologists up here. It's the golden age of being in CT imaging. We're all companies that are unsettled by the fact that heart attack and stroke remain the #1 killer globally, yet 80% preventable. Like, how can that be? And that's something we're going to talk about in today's talk of what Elucid has. So we'll talk about the problem right now of technology limiting you to not be able to see beyond same data, different disease. We'll talk about how looking at this problem from a single focus of anatomy, biology, or physiology alone is not the way to do it. Integrating at the lesion level is our belief is what's going to get to personalized medicine. We want to deliver BioIntegrated FFR. I'll talk what that is, and that's a very high, the highest algorithm validated that FDA has seen. They're reviewing that today. And then we already have Plaque-IQ on the market, which is the only non-invasive method that's FDA cleared to quantify the lipid-rich necrotic core, which if you don't have, you're not having a heart attack. If you do have, you're much more likely. So we're looking to bring to you in the market in the immediate term, get you Plaque-IQ and FFR-CT so you can start making meds and cath lab decisions better with integrated readouts. And then in the future, prospective randomized clinical trials to talk to you about integration of anatomy, biology, physiology, and other prognosticators of risk that we as Elucid, we look at our job as using AI to help you see invisible features in non-invasive heart scans, and AI is great for that. Same data, different disease. You look at this 2 cases, there's plaque, total plaque volume, CAD-RAD, stenosis, very similar. The guidelines today will tell you to go to a nomogram and look at age and gender, and there's a statin level recommended. And that's, you know, insufficient. When I give you the biology and I tell you that case 1 is all calcified plaque, case 2 is all heavily lipid-rich necrotic core and it's abutting the lumen, your decision making now becomes much different now that you have biology on top of that anatomy. And that's something that we'll go into deeper. Cancer, like oncology has walked this path over the past 20 years. If you think about oncology, breast cancer, 20 years ago, it was anatomy. Size and staging was it. Everybody got the same chemotherapy or surgery. Then receptor presence, biology, physiology, CT PET, how active is it? And then eventually genomics for is it aggressive, indolent? Is there a recurrence risk? These all now take into account personalized medication decisions for that breast cancer patient, whereas 20 years ago, it was just high-dose chemo. Elucid's vision, CCTA 1.0, a lot of the scanner companies room enabled better anatomy with better slice and better resolution, stenosis plaque volume, and we think it's great. But there's also plus, you know, companies like HeartFlow blazed the trail in FFR-CT. You have clearly Elucid, HeartFlow coming with AI plaque. Today, though, it's kind of an isolated view, though, of looking at FFR-CT for later stage cath lab decisions, plaque for how do I think about my medications. We're going to tell you that you got to go lesion level, and you're going to look at all 3 anatomy, physiology, and biology to make your decisions, and that's 3.0. How do you integrate that? And then again, how do you do prognostic risk factors like HALT, a series of prospective randomized trials to get to optimal, I should say personalized optimal medical therapy, and then AI Predict, which is you saw first patient enrolled, thanks to many doctors in this room. We're looking for prognosticators, much like Prospect and 1 and 2 found TICFA. I can tell you that if we can discuss with you and tell you a lesion has the time to rupture versus a time to medical stabilization, you're going to think about, I stabilize with medicine if I have time. If I don't, that patient should get a PCI procedure done, even if it's hemodynamically insignificant. And this is known for a long time. If you look at this work of Narula Motoyama, you definitely see that if there's FFR positive and HRP positive, revascularization has a much better event rate in the future than medication alone. However, FFR positive and HRP negative, actually, it looks like medication might be better than exposing that patient to risk. And of course, ACC 2023, the late breaker of PREVENT trial, showed that there might be, right, some benefit of revascularizing lesions that are high risk, but not yet hemodynamically significant. Dr. Stone presented that. We look forward to doing our trials prospectively with Dr. Stone in the future, as he says, when he has a better way to tell a high-risk plaque versus looking at 2 or 4 visual features, like let's measure lipid-rich necrotic core and where it exists in the vessel. So in the past, those were, the physiology anatomy was never really done. It was possible with technology interventional space, but if you talk to an interventionalist, they're not going to thread through an imaging wire and do 3-vessel imaging and then pull that out and thread through an FFR wire and do 3-vessel pullbacks and then try to co-register those onto the same. That's just way too burdensome. They're going to get through 1 or 2 cases a day. The good news is now as imagers, we're going to give you everything on one scan from your one CT scan, and we'll go through how, again, you can use anatomy, biology, physiology together to make your clinical decisions of cath lab and medication, and not in isolation. We believe, and we're going to show you, FFR, full vessel on top of plaque, because our results are, FFR is based on plaque, and we'll talk about that. They're always concordant, so there's no harm in showing you all the data in one place. We can do this because fundamentally we built CT virtual histology. As you know, visual assessment is great for plaque analysis, but the human eye cannot see the shades of gray that the lipid-rich necrotic core lives within, and that lipid-rich necrotic core is the driver of lesion rupture. So we did a long, hard study with Dr. Renu Vermani, patient with CT scan, vessel harvested. She sectioned and stained them, and as we all know, different tissue types stain different. They stain differently. This is quantitative. It's very highly reproducible, and we just matched the CT slice with the histology slice over and over again about 1,000 times, so our algorithm can see what the human eye can't see, and we have multiple patents on matching CTs to objective criteria like histology. So the gold standard for cardiac plaque analysis, but we don't want that gold standard if we're living done on us. So as Dr. Rogers said, we painstakingly spent a lot of time on accuracy, reproducibility. You'll hear 4 abstracts today and posters at this meeting on accuracy, reproducibility, and then even as we develop our FFR-CT with the FDA today, we developed that with a model, a group of AI experts, and a training set that has superior and very high AUC sensitivity and specificities, something that has not been commercialized to date. And then, the idea of like same anatomy, different disease, we talk about BioIntegrated FFR. Dr. Ahmadi has a lot of background on how the kind of plaque in the vessel really affects vasodilation. You'll hear Dr. Min talk about plaque-based FFR, the same insight that plaque-based algorithms incorporate not just physics of luminal narrowing, but the fact that vasodilation can be greatly impaired by the plaque in the wall. So under hyperemia, you might have vessel dilation. You can't expand around that plaque that causes stricture, dramatically influences flow. So here, if you look at the physics of this and the anatomy, same stenosis, 2 cases, same lesion length, you might say from a physics point of view, the FFR is identical. Actually, because of that lipid-rich necrotic core presence, you have 70% greater delta FFR, and again, we also agree with Huang in the Emerald 2 study, delta FFR greater than 0.1 should be a concern, and you should think about that as you look at also the lesion biology. So we want to give you a platform. We intend to give you the most accurate FFR-CT compared to invasive FFR. We're going to give you easy reporting. That top bar, if you want to do a quick clinical case, that's everything you need in your patient report. We give you full vessel FFR, and then we also give you the transparency of going back to your original CT scan. You can, every step we took, you can see where we put the wall and the lumen. Your eyes, you can say, do I see positive remodeling? Do I agree where Elucid's saying there could be some lipid-rich necrotic core? And then here I'll show you a case where actually, yeah, there's lipid-rich necrotic core, and from a medication point of view, this total plaque volume would say high statin treatment. Now I ask you as clinicians, would you consider now anti-inflammatory? Would you also consider dual platelet therapy as part of this regimen? So I think having this biology also now influences your medication decision making. In addition, since we are plaque-based in our FFR, you can do full vessel FFR, you get the pullback curve, and here's a case where it's going to the gray zone. You could decide to wait and watch this because it's a gray zone case. But you look at the biology and say, wow, that LRNC in red is in a sea of non-calcified yellow with a small amount of calcified stable plaque. As that approaches the lumen, right? Prospect 1 and Prospect 2 shows us that is going to go greatly higher risk of rupture. So you may want to send this person to cath lab. So now you're thinking differently about cath lab. Now you have biology, you have the anatomy, and you have the physiology all laid in the same place. I talk to a lot of doctors that are trying to take flat reports, go back to Terra Recon and look at where the geography, the reports you're talking about. We want to give you everything. We want to fully transparently show you the scan you gave us, how we built the analysis. We want you to understand the results. FFR drop, it's stenosis, but it's also plaque biology. And if you decide to go to the cath lab, we have a lesion analysis tool. You can size the stent, place the stent. If anybody was at the Optimizing PCI meeting at St. Francis, 6 vendors were given a bake-off, and Elucid was declared the winner, the only one to get the actual sizing and stent placement correct in that interventional procedure where they provided CT scans. So all that, I want to give you that wrapped in an easy to understand, best info to clinical insight platform. Again, your patient level information to do your case. You want to dig deeper to SCCT segment level information. We have that for you. And then you want to go to the lesion level where really heart attacks happen, right? You never have a heart attack because an entire vessel collapses. A single lesion ruptures. We give you the lesion assessment tool, and you can dig in and get to that reporting in a DICOM structure report and working with companies to do PowerScribe to automate a lot of that. So I talk to doctors and show them that it's really hard for that doctor to go back to trying to diagnose a patient by looking at anatomy alone. So that's our premise. I could tell you that we want to go to market and help, with FDA clearance of our FFR, the ability to give you accuracy, transparency, always concordant results, actionability that you can make medication and cath lab decisions differently, and join a journey to get cardiology to personalized medicine so you can treat me different than my brother, even though risk factors and family history are the same. So Dr. Amati will talk more at this conference about taking from patient level information, total plaque information, now to physiology, anatomy, biology integrated, the trials that we have going on. There's an investigator meeting for our HALT series coming up on Saturday. So come with us, join with us, and we'd love to talk to you about our FFR integrated platform with plaque biology. Thank you very much.